Dr. Anna, shall we start?
Yes.
Do you want me to start?
Yes. Now, can I start now?
Yes, please, Dr. Anna.
Yes. Dear colleagues, good evening. I'm Anna Ufarahayu, a cardiologist senior consultant for congenital heart disease at the National Cardiovascular Center Harapan Kita, Jakarta, Indonesia. First of all, I would like to extend my high appreciation to our colleagues from the Pediatric and Congenital Heart Disease Center, Heart Center of the National Heart Institute of Malaysia for organizing this spectacular Asian Adult Congenital Heart Disease Conference 2022 during this hard situation of COVID-19 pandemic. And I would like also to thank the organizing committee for giving me the opportunity to chair this evening session on congenitally corrected transposition of the great arteries conundrum. As we know that ccTGA is exceptionally rare, with incidence suggested to be around 1 in 33,000 live births, totally approximately 0.05% of congenital heart disease. It is a unique congenital heart lesion in the sense that despite anatomical aberration in the form of atrioventricular and ventricular arterial discordant or double discordant, there can be physiologically normal circulation without any mixing or shunting of blood. The indication for and technique for surgical correction of ccTGA continue to evolve. We are very fortunate to have two prominent speakers in this session. That's Clinical Associate Professor Tan Julie and Professor David Barron. Dr. Ahmad Farhan Ahmad Hamid will present two cases, and afterward we will have discussion. Let me start with the first speaker, Clinical Associate Professor Tan Julie, Director of Adult Congenital Heart Disease Program, a Senior Consultant Cardiologist, National Heart Center, Singapore. She is specializing in adult congenital heart disease, management of cardiac disease in pregnancy, echocardiography, and pulmonary hypertension. Dr. Tan was trained at the Royal Brompton Hospital in London from 2003 to 2005. She's also a clinical associate professor at the Duke National University of Singapore, graduate medical school, and a senior lecturer at this institution. She also runs the joint monthly cardiac obstetric clinic with the obstetrician from the Singapore General Hospital. Dr. Tan is active in clinical trial and research, especially in hyperlipidemia and pulmonary hypertension. She has written numerous publications. She is also a co-author of several books, chapters, and a reviewer at the International Journal of Cardiology and local journals like the Annual Academy of Medicine, Singapore. Dr. Tan will talk about tricuspid regurgitation in unrepaired ccTGA, tricuspid valve replacement, or pulmonary artery bending. The next 20 minutes is yours, Dr. Tan.
Thank you very much. Thank you, Prof. Anna, for your kind introduction. And first of all, I would also like to thank Dr. Leong for organizing this ASEAN ACHD webinar running every Thursday for most of March. And he's given me a very tough topic today on tricuspid regurgitation in ccTGA, tricuspid valve replacement or pulmonary artery bending. I have no financial disclosure, but I would also like to disclose that I'm not an expert in ccTGA. I've done some reading, and I'd like to share with you some of my readings and my knowledge and understanding of this condition. So my talk today is neither extensive or exhaustive, but I hope you can have some, but I hope there's some take-home message and there is some knowledge sharing. Okay. First of all, I like to this talk by actually giving on two of my patients with ccTGA. The first one is a 51-year-old man. He works as a personal trainer. He's completely asymptomatic. He presented in 2017 with syncope and complete heart block. Subsequently, he had a CRT done. And echo on, in 2021 shows that his RV function is impaired with a TAPC of 16. He has a mild to moderate TR, a small ASD. An MRI was done which shows a systemic RVEF of 35%. A CPAP showed that actually he did pretty well. He had the VO2 max was 30, which was 102% predicted. This is not surprising because this guy is a personal trainer and he exercises every day and he goes to the gym every day. So on the other hand, I have another gentleman. He's 47-year-old. He's a bit more sedentary. He also has ccTGA, but he had a physiological repair, having had a Rastali conduit VSD and ASD closure a couple of years ago. And his echo in 2021, his RV function is overall not too bad, 46%, TAPC is 19. He has moderate Rastali conduit stenosis. And his MRI shows his RVEF is 42%, which is better than the first patient. But his CPAP is not as good, it's only 89% predicted. And you can see from here, the echocardiogram for the first patient, you can see that the RV, which is on the patient's left side, is a little bit globular. There is some septal flattening. There's a CRTD lead. The TR here is probably mild to moderate. The second patient, on the other hand, the septal shift is less prominent. The septum is a bit straighter. And the RV is less globular because the patient has a moderate conduit stenosis. However, he does have a moderate degree of tricuspid regurgitation. So just to give you a flavor how two patients can be completely different. The first patient does not have a pulmonary stenosis or conduit stenosis, but the second patient has. So I just want you to note subtly this change, this difference in the interventricular septum between the two patients. Now, today we're going to talk about what is the etiology of tricuspid regurgitation in ccTGA. So it's good to understand how tricuspid regurgitation results. What is the data of tricuspid valve replacement for TR in ccTGA? And then what is the data on pulmonary artery bending? And then we can conclude. Now, we know that the long-term outcome of patients with ccTGA is a little bit different, right? Depends also if they have associated lesions or they do not have significant associated lesions. So this paper published more than 20 years ago, looking at two groups of patients, one with significant lesions and the other one with no associated significant lesions or with very small VSD. So you can see in the first group, which is group 1, patients with significant associated lesions tend to do a little bit worse than those with no associated lesions in terms of RV dysfunction and in terms of congestive cardiac failure. But we should also appreciate that with time, over the years, both groups continue to see a degree of RV dysfunction, worsening RV dysfunction, and a higher incidence of congestive heart failure as time goes by, right? So therefore, patients with ccTGA are increasingly subjected to RV dysfunction and congestive heart failure with increasing age, more so if they have associated lesions, right? So what is the etiology of TR in this group of patients? So we know that ccTGA patients have variable natural history, depending on the severity of the cardiac lesions, as we have seen, depending on their RV dysfunction, depending also what is the severity of the TR and if they have abnormal tricuspid valve to start off with, and of course, also the development of any arrhythmias, right? Systemic RV loading, we know over time will change the RV geometry. This can affect the RV function, worsen the TR, and predispose to congestive cardiac failure. So this you can see an MRI of two patients of, the similar patients with ccTGA. So you can see with ccTGA there's RV hypertrophy, and this invariably is followed by RV dilatation. The RV then becomes more spherical, the receptors shift, the tricuspid annulus dilate, pulls the purpura muscle away. There is often feathering of the cords. The tricuspid leaflets are unable to coapt. And in addition, some patients with ccTGA even have Epstein-like thickening, making the TR even worse. So this is an echocardiogram of a patient where you can see there's tricuspid annulus dilatation, purpura muscle is pulled, there's tethering of the cords, and then resulting in severe tricuspid regurgitation. So what is the role then of tricuspid valve replacement for TR in this group of patients, right? So first of all, before we look at the role, but what is the issue of progressive tricuspid valve dysfunction? How does it affect the survival of patients with ccTGA? So this rather old paper that's published more than 20 years ago, look at the survivor, 20-year survivor rates for patients with ccTGA, whether they are operated or whether they are unoperated, and also whether they have TR or no TR. So regardless whether they are operated and unoperated, you can see that the survivor is much better if they don't have TR, right? So you can see that on all patients, the patients who don't have TR do much better than patients with TR, regardless whether they're operated or not. And also this paper showed that the mean time from onset of TR to documentation of RV failure was 5 years. So this is quite important, meaning that, if you wait and wait and wait, you really cannot wait for too long, because you only have about roughly 5 years before there is documentation of RV dysfunction.
Yeah, good.
So we know that TR is a major risk factor for ccTGA, and with RV dysfunction resulting from long-standing TR. So in this paper published by Mayo Clinic, looking at 46 patients with ccTGA and severe TR, and they divide this patient into two groups, whether the RVEF is more than 40% or RVEF less than 40%. The follow-up was for 8 years. So you can see that in patients with pre-op RVEF less than 40%, even after you do the tricuspid valve replacement, majority of the patients, the RVEF remains poor, less than 40%. Only 2 patients where the RVEF improved. Whereas if you have you do the tricuspid valve replacement when the RVEF is more than 40%, majority of the patient, the RVEF remains more than 40% after the tricuspid valve replacement, right? And if you follow this patient up for up to 10 years, you can see that survival is so much better for patient in which the RVEF is more than 40% when you do the tricuspid valve replacement. And in this paper, the only independent predictor for more than 1 year survival was the pre-op as RVEF. So hence, tricuspid valve replacement should be done at earlier stage before the RVEF falls to less than 40%. So what does the guideline say? So if we look at the 2018 ACC/AHA guideline, tricuspid valve replacement is recommended for symptomatic adults with ccTGA and severe TR, but with preserved or mildly depressed RV function, and that would be a class 1. And if the patient is asymptomatic, that will be a class 2A. However, systemic RV dysfunction, often attributable to long-standing TR, can result, and that effort should be made to relieve the TR before worsening RV dysfunction. In the more recent guideline, in the ESC guideline, they even actually put a value to the RVEF. So if you have severe TR and RVEF more than 40%, and if you're symptomatic, it's a class 1 indication, right? If you're asymptomatic, it's a class 2. However, if you have severe TR and the RVEF is less than 40%, you can still consider tricuspid valve replacement, but then it becomes a 2B indication, meaning that it may benefit only some patients. In the recommendation, is basically consider doing that before the function deteriorates. Replacement. So here is some more recent data published in 2018 from Pumurai Hospital in Beijing. So here you have 57 patients with ccTGA who at least had the moderate TR. And the younger patients had tricuspid valve repair or plasty, sparing them tricuspid valve replacement. But 46 patients who are older had tricuspid valve replacement. And again, looking at the data, so generally, the long-term regurgitation is more frequent in the patients who had repair. And in this group of patients, if your RV end diastolic diameter is more than 60, the outcome is poor. In fact, at 10 years, there's hardly any survival. So therefore, in this paper, the is really you should always too late, and certainly before the RV gets too dilated. So what about pulmonary artery bending for TR in ccTGA? Okay? Before we look at pulmonary artery bending, we must first of all understand how did this idea of pulmonary artery bending come in the first place, right? This is basically from observations that patients with ccTGA and the presence of concomitant pulmonary outflow tract obstruction tend to do better. Looking at this data of 117 unoperated patients, who either have intact pulmonary outflow tract obstruction, at least a gradient of more than 35. So you can see that in this group of patients with VSD and pulmonary stenosis tend to have better RV function and less degree of tricuspid regurgitation. I'll show you this in the slide. So you can see these patients are divided into 3 groups. So whether they have VSD or no VSD, and then those with PS. So you can see that in this group with pulmonary stenosis, there is less frequent patients with severe tricuspid regurgitation as opposed to patients with intact ventricular septum or VSD but with no PS. So if you don't have PS, 43% has severe TR, 52%, but only 11% has severe TR in patients with PS. And also, systemic ventricular function is much better in patients with PS. So the RVEF is 62% as opposed to 56%. And patients who have less RVEF of less than 40%, 0 patients in this group with pulmonary stenosis. But 11% in patient VSD and 14% with intact ventricular septum. So what is the effect of PS on patients with ccTGA then? So we can see from these 3 groups, less TR, RV less dilated, and RVEF is highest. Why? Because if you have an increase in RV afterload, and LV afterload, sorry, the LV pressure is higher, and this is going to shift the septum towards the midline. So making the RV less spherical. And this kind of LV interference on the RV will move the attachment of the tricuspid septal leaflet and improve the tricuspid valve coaptation, thereby reducing the tricuspid regurgitation. And when that happens, the tricuspid annulus decrease in size, and this will decrease the TR further. Right. So in another study looking at another group of patients with ccTGA and pulmonary outflow tract obstruction, again, you can see that TR severity is less in patients with concomitant pulmonary stenosis. And in patients with PS, there's a less significant TR and a less systemic RV dysfunction. Right. So the patients with outflow tract obstruction, the mean progression-free interval for the composite endpoint actually increased from 11 to 18 years. Means that if you have outflow tract obstruction, you have a longer interval period before you achieve the composite endpoint. So hence, there are data to suggest that outflow tract obstruction in the pulmonary improve event-free survivors in patients with ccTGA. Right. So what if there's no native pulmonary stenosis? So does adding a pulmonary artery band make any difference to the TR? So here we look at papers particularly answering this question. However, most of these papers are on neonates. So we look at a paper published quite many years ago, 11 asymptomatic patients, 7 neonates. The mean age here is only in infancy, 1.5 months, followed up for about 2 to 4 years. In this group of patients with PA bending, you can see that TR remains stable, decrease in 3 and worsen in 1. So at least in the midterm evaluation, tricuspid valve function was stabilized or improved. If you look at a little bit older patient now, median age of 1.1 years, and this patient, 30 patient had ccTGA had PA bending, as opposed to 16 patient had the physiological repair. So in patient with PA bending, where they bended until the LV systolic pressure is more than 2/3, so this result so that severe TR decreased from 64% to 18%. However, in patients with physiological repair, right, the TR actually increased a little bit. So therefore, LV pressure in patients with ccTGA does affect the degree of TR, and that septal shift caused by changes in the LV and RV pressure is an important mechanism. Okay. Looking at PA bending as a palliation of systemic RV function, and this one I'm getting older and older now. So these are patients with 4.3 years of age, right? Still pretty young. Okay, all 20 patients are alive at follow-up, and most patients, the TR improved at clinic visits. Okay, so how about if you use it as a palliative in patients where the LV has regressed? So these are patients, median age 3.1, but you have some from 2 months to 10 years, follow-up about 3 to 4 years, and again the RVEF has improved, and the TR severity also improved, right? So I guess all of you are waiting for me to show you what's the data about tricuspid valve replacement versus pulmonary artery bending. So there is no data, unfortunately. I look at the internet, I search literature, I cannot find any data with direct comparison, because I think this is very difficult to have this kind of data, because ccTGA patients are rare, and it's difficult to do a trial to look at this group, to divide this patient, you know, to do either PA bending or to do tricuspid valve replacement. And most of the data I show you on PA bending are on infants and young children. There are very limited or hardly any data at all in adults. So prospective trial difficult to conduct, right? And also to follow up for a long period of time to make up for the small cohort of ccTGA patients. So here are my thoughts. So I think in patients with ccTGA where there's severe TR and RV dysfunction, where current guidelines says it's a 2B indication, can PA bending be performed first to improve RV dysfunction and maybe improve TR severity? So maybe that's enough. But if the TR is still severe but RV function has improved, you know, and then the patient will then move from class 2B indication to class 1 or 2A, depending if the patient is symptomatic or not, then we can then do the tricuspid valve replacement. So these are my thoughts, but again, I cannot find any data to substantiate this. So in other words, ladies and gentlemen, tricuspid regurgitation in ccTGA patient is a combination of RV geometry changes causing TV annular dilatation, caudate tethering, and some patients has Epstein-like abnormality. The development and progression of TR carries a worse prognosis in patients well operated, and TV replacement should be performed before RV dysfunction progress. Both the AHA and ESC guidelines recommend tricuspid valve replacement for adult ccTGA patients with severe TR as long as the RV function is preserved or mildly depressed. And if the patient is symptomatic, is class 1. If it's asymptomatic, is class 2A. In the ESC guideline, patients with severe TR and RVEF is less than 40%, it may still be considered, but it's a 2B indication. And in patients with ccTGA with pulmonary stenosis, small retrospective studies have reported better outcome with regards to TR severity and systemic RV dysfunction. Small retrospective study in neonates and young children have shown stabilization and improvement in TR and RV function after PA bending. There's really not much data in adults at all. So there's limited or no data available comparing directly PA bending with tricuspid valve replacement. But you know, can we use that as a treatment option in adult ccTGA patients with severe TR? This is a thought, but I've got no data to prove it likewise. Thank you very much for your attention. Thank you.
Thank you, Professor Tan. Yes, for the excellent presentation. I know this is not a simple problem, and you have explained us clearly. Yes, because Professor David Barron has an emergency to attend. I think we will proceed with Dr. Ahmad Farhan from Institut Jantung Negara Malaysia to present his cases.
Sorry,
Yes.
Prof. Anna, I think David is here.
Oh, okay then.
He's logged in as FTTS team.
Should I proceed with Professor David Barron?
Yes, please.
I think. Hi, I'm really sorry. I'm sort of all doubly booked up this morning, but that was an excellent talk. But if you've got another talk to go, why don't you go ahead with that? And as I say, hopefully I can join the panel to discuss it afterwards.
Okay, that's fine then. Well, I ask Dr. Ahmad Farhan first to present his cases.
Hi, good evening, everyone. I'm actually presenting two cases. I've been given the task to present two cases, and we're actually going to discuss the expert panel opinion surrounding these two cases. If I can just share my screen.
We haven't seen your slide, Dr. Ahmad.
Okay.
Yes, fine.
You can see my slides, okay?
Yes, it's clear.
Okay, thank you. So we'll go through the two cases very briefly because I like to spend more time discussing the expert opinion surrounding these two cases. So the first case is Madam PL. She's a 36 years old housewife. She was actually referred to the hospital at the age of 6. However, following her initial assessment, she disappeared from our radar. She was re-referred again. So she appeared again at the age of 26. She was re-referred from a district general hospital to our hospital at the age of 26, by which time she required a permanent pacemaker for complete heart block. So she has ccTGA with a moderate tricuspid regurgitation. And in 2013, she had a permanent pacemaker implanted. And she had the LV leads, her leads screwed to the left ventricle and to the right atrial appendage. Unfortunately now, she has a failing systemic right ventricle. Nonetheless, she remains in functional class 1. She complains of missed beats and just vague chest discomfort. Her only medication is enalapril, 2.5 milligrams a day. This is a chest X-ray which shows a cardiomegaly. She's got dual chamber pacemaker in situ. Her lungs are clear. This is an ECG which shows atrial sense, ventricular pace, broad QRS complex. In summary, her echo shows she's got a moderate tricuspid regurgitation. Her left ventricle is small. Her left ventricle is small because of the she has a dilated right ventricle. She has no mitral regurgitation, and her indices of right ventricular function are impaired. We've never been able to perform CMR because her pacemaker is not compatible with CMR. This is a summary of a cath data from back just over 3 years ago. Mean PA pressure of 18. Her left ventricular pressure is very much lower than ideal than the systemic pressure. She has had a 24-hour Holter monitor.
Baca buku nak exam lah tuan tepuk.
Can you unmute the other sound? Yes.
Okay.
Continue.
So she's got some VPCs on her 24-hour Holter monitor, 1.93%. She's essentially pace independent, 97% morphological LV pace, and RA pace at 10%. Her NT-proBNP level is not elevated. Now we shall return to her case and compare with the second case, and we shall discuss similarities and differences in terms of management for the two cases both together. So this is the second case, Mr. MZ. He's a 32-year-old gentleman, a welder for heavy machinery works. He was referred at the age of 6 years old. He's got the diagnosis of ccTGA with an abstenoid valve. At the age of 15, he had PA bending with a view for arterial switch and sending procedure. However, due to changes in the local circumstances back in 2005, a surgeon was not available to perform a double switch operation. Nonetheless, catheterization restudy back in 2007, just 2 years after, a year and a half after PA bending, showed that the LV, his LV is not adequately trained. So now he is 32 years of age. He has got severe tricuspid regurgitation. His systemic right ventricle remains preserved. His ECG shows resting sinus bradycardia with a marked first-degree AV block, a PR interval of over 300 milliseconds. He's currently in functional class 2. He has no symptoms of pre-syncope or syncope. Chest X-ray shows borderline cardiomegaly. He's got sternal wires, lungs are clear. This is his ECG. Most of his ECG shows sinus bradycardia with prolonged PR interval, narrow QRS complex. On one of the ECGs showing junctional rhythm. This is his echocardiogram. In summary, tricuspid valve leaflet is dysplastic, it's abstenoid. He has got severe tricuspid regurgitation, but biventricular contractility remains good. It's a bit slow, yeah. Severe tricuspid regurgitation. So both ventricles appear to have good contractility. Sorry, it's a little bit slow. And you can see on the other image displacement of the tricuspid valve. This is his CMR. Compared to a CMR in 2020 shows that the right ventricular ejection fraction has somewhat decreased compared to a prior CMR. However, nonetheless, the ejection fraction remains preserved. This is a summary of his CAF data. Unfortunately, the PA gradient across the PA band shows the PA band is rather loose, and his ventricle morphologic ventricle is not adequately trained. This is his stress test result. He had a cardiopulmonary exercise test, a VO2 max of 24 mils per kg per minute. He had a good heart rate response at peak exercise. The PR interval did not change at peak exercise. He had some ectopics at rest. Nonetheless, they disappear on exertion. He has transient SVTs on recovery and atrial and ventricular ectopics, probably related to bradycardia. 24-hour Holter monitor shows a maximum of 2-second pauses events. He has occasional VPCs and a prolonged PR interval, but no evidence of complete heart block. His more recent NT-proBNP is on the rising. So putting together these two cases, in summary, the first case, a lady who has a ccTGA with moderate tricuspid regurgitation, who has had a pacemaker, and now has a tricuspid regurgitation and a failing systemic right ventricle. And the second case, a gentleman who has ccTGA but with an abstenoid valve. He has had a PA band, but his morphologic left ventricle is not adequately trained. He now has severe tricuspid regurgitation. His systemic ventricular function is preserved. And we anticipate that he will require a pacemaker at some stage. He has VPCs induced by bradycardia. He is at risk of arrhythmia should there be an R on T phenomenon. He's also at risk of a high degree AV block. I wish to inquire panels of expert opinion on various domains: echocardiography, valve surgery, heart failure, PA band, and pacing.
Yes.
In terms of from a perspective of echocardiography, what would the panelists feel would be sensitive echo parameters for surveillance follow-up for patients with systemic right ventricle? It's a systemic right ventricle, so surely we shouldn't be using echo parameters such as ejection fraction for a systemic left ventricle and fractional area change and TAPSE for subpulmonic right ventricle. In this lady's case, we were monitoring her right ventricular function. Unfortunately, there was a sudden drop. My second question would be, in the presence of tricuspid regurgitation volume low, what would be the appropriate way to assess right ventricular function?
Yes, I would like to ask the two speakers possibly to give their opinion in these two cases. And a question from Dr. Ahmad. Dr. Tan, Julie, first.
Thank you. Thank you for presenting these two very interesting cases. And there's a lot of data. I try to write some so that I can understand, but there's a lot of data which I don't have. But in GIST, you have two patients that are very different. The first patient is a 36-year-old, is a female, and the problem with her is more, the TR wasn't that bad. It looks, moderate at most. But the concern here is the ventricular function, the failing ventricular function. And the TR, I think, is failing RV dysfunction. I don't think doesn't look like any abstenoid valve. Whereas the second case, that patient has severe TR more because of a tricuspid valve abnormality. And the good thing is that the systemic RV function is preserved. But again, we can question, how do you say in patients with severe TR, what is a normal TAPSE in this patient, right? So how do you assess on echo? And if you have an MRI, then great, because I guess, you can do an RVEF, but is that the best way? Is there any data on strain? So these are all so many questions that we don't really have an answer, right? So, but I want to just add before I forget, the first patient, which has a complete heart block and is on dual pacing, and I just wonder if you treat this as a failing systemic right ventricle, like a failing systemic left ventricle, and there has been some, even on guidelines, some role on pacing, and whether this patient would benefit upgrading the pacemaker to more of a kind of biventricular pacing. more of a CRT, you see, for the first case. So that I'm not sure whether there's a role, but certainly, you know, with the dual chamber pacemaker and the RV failing, so that may be one step to go first. Then your next question is with the systemic failing RV ventricle. And here you have echo. What's the sensitive echo parameters to use?
Yeah,
right?
so echo parameters first, and then we'll get into the pacing shortly.
Ken. All right, okay, Ken. So what do we normally use for systemic RV? So most of the patient, if it's systemic RV, ccTGA, situs solitus, so most of the time the RV is in the left, in the patient's left side, right? So some people have done, you know, getting like a 4-chamber view, 2-chamber view, and trying to estimate an RVEF like you do an LVEF. This is not entirely correct because after all, RV has 3 parts to it. But this is at least, it's almost akin like you're doing an FAC, but this one is on the left side. So certainly you can use a TAP-C, but the question is, what is the normal TAP-C for systemic RV, right? We cannot possibly use the normal TAP-C of 17 or more, which is for subpulmonic, for the subpulmonic RV. But what is a true number? And this is something which we don't really have. So many years ago, when I did looking at RV function in patients with subpulmonic RV, in systemic RV, and then in systemic LV. So I find that patient with systemic RV, the TAP-C lies somewhere between the subpulmonic RV and then the LV MAP-C. It lies somewhere in between. But I cannot tell you what is a good number for this patient. So certainly, if you have serial follow-up, then you know that if the serial follow-up, the TAP-C is getting worse and worse, then the FAC is getting worse and worse, TDI is getting lower, you know that this is clear deterioration, right? MPI and all this you can use, but again, what is a normal for systemic RV? I'm not so sure. If you can do MRI, then MRI is another method that you can use, but for patient with pacemaker, you can't use. So in the context that RV is systemic and there's on top of that TR, volume loading, then the number must be higher even than a systemic RV TAP-C. So this has to be even. So the patient with case 2, the TAP-C cannot be normal. So let's say if a normal TAP-C for systemic RV is 20, let's say, this with a severe TR, you expect easily to be 25 or even 30, right? But I don't have the data that says 25 is normal for this group of patients. Yeah, I don't have anything to add. Yeah.
How about spectral tracking mode of echo, Professor Tan?
So you can do strain. Certainly you can do strain, but strain is supposed to be more sensitive than the RV. So we have used strain, but if you use strain, it's mainly because I'm following the patient out every 6 months to a year. I'm not using strain to say, okay, a strain of systemic RV of 21 is normal for systemic RV, right? So I don't know what is the normal strain for systemic RV. Is this, I mean, if you take as more than 20 for subpulmonic or 21, is this 25 normal for systemic RV? I don't have those data. Yeah, you can certainly use serial follow-up, but absolute numbers, I don't know. Yeah.
Thank you, Professor Tan.
Professor Barron, do you have any opinion on these 2 cases?
Oh, thank you very much. They're great cases, beautiful presentations, and a lovely talk beforehand. You know, they're really interesting, and they really do focus, I think, on the typical problems in adults with ccTGA. So Farhan, I would say, so exactly the second case, the man who'd had a previous band, it's very interesting to look at him, because you can see, if anything, maybe that band, even though it wasn't good enough to train him for a double switch, it does look to have sustained his ventricular, his septal positioning, and his function looked quite reasonable. But nevertheless, for sure, he's got probably severe TR, and you've seen that data shown that once you've got severe TR, you're in a bad prognostic group. But if you've got well-sustained RV ejection fraction, which he has, then he's probably the group that will benefit most from going ahead with the tricuspid valve replacement. So I think that's definitely the right thing for him. And although he's got some sort of first-degree block, he's got a good rate response on exercise. So I don't think pacing particularly has a role in him. but I would think a tricuspid valve replacement and probably leave his band on would be the right thing to do. It's certainly, people talk about, can you repair these valves successfully? And the evidence is no. They're very difficult and resistant to successful repair, sometimes because of the, they're Ebstenoid type valves, sometimes because of that septal movement, but repair just does not work. And there's a very sort of seminal paper from Alain Carpentier, who was the real father of mitral valve repair, who tried to repair tricuspid valves in ccTGA, and he had 100% failure rate. So in the best hands, you can't repair these valves. So go straight for a replacement is the right thing to do. Then your first lady, obviously much more challenging.
Yeah.
As I think, as Professor Tan said, I would definitely think that CRT or some sort of biventricular pacing is probably the first thing to try. But even in her, probably if you were to consider a tricuspid valve replacement, might at least stabilize sort of ventricular function, but she's more challenging because she's already in failure.
Yeah, she's if I may ask, so for the gentleman in the second case, do you feel, Professor, that the timing of tricuspid valve replacement is now?
Yeah, I think so. I think so. You've got evidence he's not got normal exercise performance. He's got severe TR. And actually that Mayo data suggests that if you can replace these valves before their ventricular function starts to deteriorate, then actually their prognosis is pretty good.
Okay.
Yeah.
What about the, sorry.
Yeah, Professor Barron, there is a question from Dr. Gita. Is there an age limit with regard to the timing of pulmonary artery bending? As far as I know, if it's done above 2 years of age, then the result will be not as good as the adult age.
Yeah, it's a really important question, because there's a lot of data out there, but it's almost all in children. And so you see these big series of double switches and banding, and there's often just 1 or 2 patients who are much older, usually teenage. And so the question gets asked, well, can you band and retrain in older ages? And there are anecdotal cases where you can, but the truth is, or really the vast majority of data tells us that really you are not going to be able to retrain a left ventricle effectively or reliably once you're over about maybe 10 years of age. And all the best results are when you put a band on below the age of 2 years. So when we're talking about an adult age group, really banding is speculative at best. But that really interesting question of is there still a role for it to try and splint the ventricular septum and improve tricuspid valve function, we don't know. And I think we're desperate really for somebody to start doing some banding in older patients just as a means of sustaining tricuspid valve function. But it's a very big step to do, because often that in itself is quite a big undertaking. You're not really sure what the outcomes are going to be. But certainly I think we're more minded that when you're doing in a situation where it's too late for any sort of anatomical repair for a double switch, but maybe say you're doing a physiological repair for severe left outflow tract obstruction, and you're planning to do a VSD closure and an LV to PA conduit, then probably it would be a good idea to deliberately choose a slightly small LV to PA conduit, to deliberately leave them with some pressure load on the subpulmonary ventricle to try and splint the septum. But I think to go down the road of just purely banding in adults, there's just not enough evidence, and it's a really sort of high risk, unknown sort of strategy. So we don't seem to have a role for putting on a primary band in adults. We just don't really know that it makes any difference. And I think we're more focused on if they've got moderate plus tricuspid regurgitation, probably the best thing is early tricuspid valve replacement. And it'll be really interesting to know the role of banding, but all that banding evidence is really in children, and all the good outcomes for banding are when you band them under 2 years of age.
Yeah. So in regards to banding, if the LV, the morphologic LV is not adequately trained, has there been any work trying to reband or retighten the band?
Yeah, sure. If you, there's some quite good data from Stanford. If you search under Mannering, main wearing, you'll see that they have had some success in rebanding. But again, these are all generally in younger patients. And the more you have to tighten the band or reband, and the longer you're having to wait for the band to kind of work, the less likely you are to have a good result. And it does seem that if you're going to get a good response from banding, you almost see it on the table when you do it, and you get an immediate response, and then that then progresses over the next few months. But patients who don't seem to respond to banding are immediately in a bad prognostic group. So rebanding on the whole isn't very productive as a kind of as a way of approach. And usually they have to respond to the initial band.
In regards to the case, the first case, the lady with the failing systemic right ventricle, do you think there's still hope to perform tricuspid valve replacement, or is it too late? Or do you
I think so. I would certainly, yeah, I would certainly consider it. Yeah, I would consider tricuspid valve replacement. But again, should you put a band on as well while you're there? Nobody knows the answer to that. It often gets asked and we don't know. I think the fact that you're going to do a tricuspid valve replacement means you've taken the TR out of the equation, so maybe the band has less role, but it may still splint the septum a bit and improve it. So I think there's an argument for putting a band on at the same time.
Okay, so if tricuspid valve replacement has been undertaken and the patient continues to have a failing heart, what heart failure medications should we use? I mean, is there a role for ARNIs, MRAs, the conventional medications we use for heart failure?
So the short answer is there is no data. We know that we all try. When we have patients with systemic RV function, we would give them all the medication for LV, but we will watch. You're not going to give them indefinitely. You want to see this improvement after maybe 6 months of treatment, but if they don't, then I think there's no data to continue them indefinitely. We haven't yet have any drugs especially for systemic RV dysfunction. So we all try ACE. We have tried ARNIs. Yeah.
Yeah. Is there a role for ventricular assist device and with a view to bridge the transplant?
Yeah, for sure. Yeah, you have to. I mean, they're being widely used. I think there are a couple of sort of technical things about using VADs in these patients. You have to be careful. It's more difficult to get the apical, cannula to sit appropriately in what is actually an RV. It's easy to get trapped in amongst the trabeculae, so you have to make sure the positioning is correct. For that, and then you also have to decide whether or not you're going to do anything about the tricuspid regurgitation. But usually, with a VAD, they'll tolerate the tricuspid regurgitation. But yes, I mean that's the bottom line, is you end up down the role of a transplant assessment and potentially for a VAD as a bridge if needs be. But they can definitely be used in ccTGA.
I have a few more questions. Sorry, I have a few more questions, if I may. With regards to the patient, the lady in the first case, failing systemic right ventricle, is it part and parcel of the natural progression of ccTGA, or could it be as a result of morphological LV lead pacing? How do we decide? Is there a role to perform echo desynchrony study?
I think it's a good idea to do so. There's certainly some evidence that resynchronization can cause dramatic recovery of systemic ventricular function, but it's slightly anecdotal in that you haven't really got a proof that there are certain patients who will and won't respond. But once you've got, as you say, you're in a pace rhythm and going to biventricular pacing, there are certainly cases where you've seen a dramatic improvement. I think on the whole, as a general comment, there's intrinsic, badness about the systemic right ventricle in ccTGA, and we still don't understand why some patients sustain good ventricular function for a lifetime and some are in bad ventricular failure, often even within 1 or 2 years of life. So there is still a mystery in ccTGA where we can't predict how patients go, but you look at all those survival curves that Professor Tan showed, and you can see that the vast majority of patients will go into systemic ventricular failure at some point. So that's probably an intrinsic problem with the ventricular myocardium or the perfusion of the ventricle rather than rhythm.
She's got 2 leads. She's got 2 pacing leads.
Yeah.
What would be your ideal site for the 3rd lead? Epicardial or through the coronary sinus, attempt through coronary sinus?
They've been done both ways, and I think when because you really want to get a lead almost on the back of the ventricle, that if it's a reoperation in an adult with a failing heart, you'd probably much rather do something in the cath lab than a pretty major procedure just to try and get a lead on the heart.
Okay. When should one consider an ICD for systemic failing systemic right ventricle, or CRTD, I presume, or we put CRTD anyway, the D component anyway in a CRT?
I think the CRT component really the thresholds really should be relatively low. So if you've got block and you're pacing dependent, then if you've still got signs of heart failure or systemic ventricular dysfunction, I think there's a good argument for CRT in all of those patients.
Okay. With regards to the gentleman in the second case, do you think that correction of hemodynamics will improve his atrial and ventricular ectopics, or should we address the arrhythmia and put a pacemaker, or consider later after tricuspid valve?
I would just replace his valve at the first instance and wait and see if that will improve things. It may well do.
Since you would have an open heart surgery, would you consider putting in a RV lead anyway?
Yeah, you could put. It would be a good idea to leave epicardial leads on. Yeah, definitely. And I say there's a couple of papers coming out from Boston of their whole experience with double switch, and of all those that have needed pacing, I think they've moved to CRT in about 70 to 80% of them.
In the first case, we saw that the NT-proBNP is still normal. Can we use it as a clue that the right ventricle function is still preserved?
I think so. I think it's valid. We certainly use it.
Okay. I think I have to conclude this case discussion, and then I would like to ask the second speaker, Professor David Barrett, a consultant cardiothoracic surgeon and division head of cardiovascular surgery, Hospital for Sick Children, Toronto. Before that, Professor Barron was a senior consultant cardiac surgery at Birmingham Children's Hospital, United Kingdom. Professor Barron obtained a doctorate from Imperial College London in biomechanical cardiac assist. Is dual qualified in internal medicine and a cardiothoracic surgeon. Amazing. He had his cardiothoracic training in several places in the United Kingdom, Petworth Hospital, Southampton, the Royal Brompton, and Great Ormond Street. Professor Burns is also active in congenital cardiac surgeon training program. He has been an honorary invited surgeon to 11 different hospitals in 6 countries, including India, Germany, and Spain. I hope Professor Byrne will also train young surgeons from our region. Professor Burns is also active in research and written numerous publications. He is interested in ccTGA, hypoplastic left heart syndrome, and complex pulmonary atresia. Professor Barron will talk about long-term outcome after surgery in patients with ccTGA. The next 20 minutes is yours.
Yeah, sorry. That was what we were explaining at the outset. I have to go to the OR now, so I can't give you any more information right now. But it's lovely to see you all, and thank you very much.
Okay, then. I think it's very clear that Professor Barron has shared the discussion, and thank you very much for your kind sharing with us your experience, and I hope next time you will also come to our webinar and talk about some other cases. Thank you, Professor Barron. You have to go to the OT.
Yeah, thank you. Thanks to my friends in IGN. Bye.
Thank you. Thank you. Is there any other question or maybe some other kind of discussion from Dr. Ahmad?
We have some questions from the audience. Shall we go through the questions, please?
Yes. What are the mechanisms causing TR in this patient, and can you predict who is going to develop progressive TR? Is there a role for prophylactic pulmonary artery bending? Maybe Professor Tan can answer this question.
Sorry, what is that question again? Do we have on here?
What are the mechanisms?
Is the question based on the two patients or not?
I think also based on your presentation, what is the mechanism cause of tricuspid regurg, and can you predict who is going to develop progressive TR?
So, right, thank you very much for the question. So if we look at the two patients, then the cause for tricuspid regurgitation in patient 1, that's the lady with the failing RV, it's really because I think it's the failing right ventricle that the RV is more globular in shape. You can see from the echo. I remember seeing the echo, and you can see that the septum is really quite globular. So I think the TR mechanism is as we have discussed. The second patient, the TR here is obviously from the valve, and that's why the TR is severe and the RV function is preserved. So these two patients, I think the mechanism of TR is certainly different. And the second part is on PA bending, is that right, on these two patients? So so the first patient, because of the septal shift, it's very attractive to think that if you put a PA band, you can straighten the septum and the tricuspid valve will improve. And there's certainly some data, at least, as I said before, in infants or in young children. So I don't see many data at all on patients like the first patient who is already 36 years old. So I don't know, right? But if there is, patient is getting worse and there's nothing much you can do. So what are your options? Your options are for the first patient, do a CRTD. If that doesn't improve, PA band. If the TR is not that bad, because the TR on some views only look moderate. Certainly if the TR is severe, I think tricuspid valve replacement you could do, but it's a 2B indication, which may improve in some patients. And I saw from the question, it say light PA band. So unfortunately, Professor Barron is not around, but I really want to ask, you're going to put a PA band, how much are you going to put? How much are you going to tighten? What kind of pressure are you going to get? Are you going to really do it with an echo there? And you have to probably have an intra-op. You tighten the band until you see the septum straightens, the tricuspid regurgitation gets less, and maybe some improvement in RV function. So here, it's a whole new ball game. How much are you going to tighten? What's the light band? What is the correct bending? What's the correct pressure? So these are all interesting concepts, and I cannot tell you that the correct band for this patient maybe is 2/3 systemic. I don't know. That is 2/3 systemic is what we use for children. You want to train the LV, but what is the correct pressure to get for her? I don't think anybody knows for sure.
Yeah. In your center, have you experienced on doing pulmonary artery bending in adult cases?
No. So as I've said, we've had 2 patients so far. So the patients, we have moderate TR, not too bad. So the patients, if the TR gets worse, I think as long as we're keeping an eye and the RVEF is more than 40%, and if the patient is symptomatic or not symptomatic, I think it's a tricuspid valve replacement first, because I guess there's a bit more data, right? So the question then becomes, if the TR is not severe and the RV is failing,
Your Honor,
postulated earlier, whether if you put a PA band and you improve the RV function, do that first before you do the tricuspid valve replacement. Will that improve the outcome? So this is attractive, but again, I don't have the data. Yeah.
How about in IGN, Dr. Farhan? Do they perform pulmonary artery bending in adult cases with ccTGA?
If you don't
I
mind,
pass that to Dr. Leong and Dr. Gita.
yeah, if you don't mind, I would like to answer that. We have done one PA bending for adult, but unfortunately we did it too tightly and the patient couldn't tolerate the PA bend. So I don't think adults can tolerate PA bend as well as children. So in adults, we would still go for pulmonary tricuspid valve replacement.
Sorry, the too tightly is what kind of pressure?
So-
were you aiming to?
so generally, we use TE guidance, and the surgeon also measures, Julie. So they will tighten the band, and the aim is to hit at least about 60 to 75%. I've also asked Mr. Siva to come on because he is the surgeon and he'll be able to share some surgical perspective. But we use the TE because sometimes you can say that you want to come up with a standard, like 60% or 75% systemic, or then some papers talk about even in the younger patients, they want to go higher, 80, 90%, see? But not every LV is able to cope. So the TE guides, so when you start to see the LV struggling or the dilating, then you know that maybe you've gone too far, so you drop it a bit. So it's a combination of the pressures and looking at the ventricle function. So we actually have, like Leong said, we don't do, after that experience, we don't. And generally our cutoff is around like 12 years and below that we would consider. However, sometimes, in a very good situation, we do have some MDTs, and then we discuss in the older patient. One of the things that we are thinking about is whether there's a role of this light band or a PA band as a destination therapy. So which is what I was hoping Mr. Barron would be able to give some input. You are right in saying that there's no data out there, but there was a suggestion under Andrew Reddington. You know how they do this conductance, so they can actually measure how the LV is coping. And in his review of, I think, about 8 or 9 adult patients, they were able to use this, because he's saying it's not so much the pressure, but the physiology of that LV. So they use this conductance, that curve, that pressure loop curve. And he has shown that in selected patients, you can, in the adult patient, do stage PA bend, not immediate. So you come back after 3 to 6 months. Yes, it's a bit of an issue because you have to open the chest again, but they have shown that some of these patients with the stage PA bend, it can be like destination therapy, and you can shift the septum, improve the hemodynamics, the RV function. And in some, I think 2 of their patients, they managed to improve the function to a stage where they were able to send the patient for tricuspid valve replacement. So this is like ad hoc, small numbers, individual patients.
So it's like a graduated PA band. You can limit
Yes,
tighter.
correct.
get a bit tighter. You know, it's like almost
Tighter.
like training the LV again for those that the LV has regressed lah.
Correct,
But in
correct.
the adult setting, you see.
So it's you have to do it. It's not just about the just measuring pressures, you know. We use the TE to guide, but he was saying that they actually do that conductance curve. So when you start to see the thing failing, then you stop. Then you come back maybe 3 to 6 months time and see. The aim here is not for training. The aim is to shift the septum, improve the RV function. And he said that in 2 of the patients, they were able to do tricuspid valve replacement, and 1 patient was taken off the transplant list.
Yes.
Yes, beside that, evaluation by echo, some experts suggest that we should measure the NT-proBNP of the bending. I think it is feasible to do. And then
it's also good for follow-up, Anna, the NT-proBNP, because sometimes it's hard to assess that RV. And like in our patient, you know, we were because we were not able to actually show the serial echo pictures, but when you actually look at it, you can see that the RV just the next review, there's already a downtrend of the RV function. So maybe by doing some more other tests like NT-proBNP, some more sensitive biomarkers, we might be able to predict that this RV is going to fail sooner than later, and maybe think about doing the valve replacement or other interventions. The other thing is, of course, exercise testing. More and more, they're talking about using cardiopulmonary exercise testing to pick up these patients, like what Julie mentioned, you know, this asymptomatic versus symptomatic. The guidelines keep saying asymptomatic systemic right ventricle, you know, you watch and see the indications like 2A. But what is asymptomatic and symptomatic in our patients who have had this disease for their whole life? So they're very well compensated when you ask. So you need some objective assessment.
do you have adjustable bending equipment? I mean, a device where we can do and adjusted the bending in your center, Greta?
We don't, although we tried, and last time in the pediatric patients, I think Mr. Siva is here, our surgeon, and he does the bands and the sending Rastali and the double switch. Maybe Siva, you can give your opinion about this adjustable bands.
Thank you, Dr. Geeta. Thank you for inviting me to be one of the panelists in this very important talk, and I thoroughly enjoyed the session so far. The adjustable band, Dr. Anna, was initially described for patients with multiple VSDs. There was a study from Professor Kono many years ago. And then there were some of the surgeons who adopted this, but then later they kind of found that it was not very useful because there are a lot of issues with the band, especially how do you do the exact measurements on the band gradient and stuff. So they're kind of given away with that. And in fact, we also tried the the adjustable band on a couple of occasions, but it didn't work. So we are totally gone away from that. So we don't do the adjustable band anymore. But may I ask a question to the, of course, this is a adult congenital heart disease session, but since I have all the esteemed pediatric cardiologists on this panel, now from the lessons that we have learned so far in all these adult patients that come to us with unrepaired ccTGAs. So managing all these issues with the systemic right ventricle has become a malady. So now what would the general consensus be from from the point of view from the cardiologist? Would you agree that we should go ahead and do early surgery so that to prevent all these issues with the systemic right ventricle, because there is still a lot of hesitancy in going for a complete surgical repair. So do we wait? Do we wait for all these problems to arise? Or should we be a bit more aggressive and deal with these patients earlier so that we don't encounter this kind of problems with a failing right ventricle in the future? Thank you.
Yes, Professor Tan, can you give a comment on Dr. Sifa's question? Based on your
Okay,
slides.
it's easy for me. Yes, it's easy for me because I'm an adult cardiologist and I don't see children. But I can understand Dr. Siva's point of view. Now, there will be two groups of patients. Interestingly, the two patients that you presented was first presented at the age of 6 to IJN. So already you missed the boat. And my two patients presented in adulthood. So no matter what, there will be always a groups of patients that are going to present late or adulthood because they symptomatic, and sometimes they could present for the first. So regardless of whether you to do early surgery, that's for patients that you get diagnosis right from the start. But a lot of patients will come a little bit late or come adulthood, of which these questions cannot be answered because it's not suitable already by the time they present to do a double switch. I only see patients above the age of 16, so I cannot tell you what's my experience with infants and all that. So by the time they come to me, it's already decided they have surgery or not. So maybe Gita or Leong can
Gita,
answer that
maybe
question.
Gita or Dr. Leong.
So I'll say, and then we'll open up to Leong and the rest. I just wanted to say that I know this is an issue about whether we should be doing prophylactic PA band and training the left ventricle and then subjecting these patients for double switch early so that we don't have to deal with this systemic right ventricles. But then we have to remember that the sending procedure per se has long-term issues with regards to arrhythmias and I think that's generally arrhythmias, but you can also have baffle obstructions and when you do it in a young patient, data has shown that within 20 years, at least 50% of them will have some form of arrhythmia, whether brady or tachyarrhythmia. However, we do know, and Julie, you are seeing the adult patients who are well and only present much later. We do know that there are many of these ccTGAs who remain relatively well for many, many years and only start to show, the natural history shows that the RE dysfunction and the start of TR is about 35, 40 years of age. So imagine you've done a sending Rastali for that patient when he was a neonate or not neonate, infant or a 2-year-old. The patient would have had a lot of morbidities by the time the patient reached 30 or 45 years. So I think it's for this group of patients, we really need to, for one, maybe you can have a particular center that does only this practice and then look at their data. I don't know, Siva, you might have some data from some surgical centers. I know some of them actually have a protocol where they train every patient and do double switch. But I also feel that we have to take into consideration the long-term outcomes of the sending procedure. And even though we say arterial switch, there's not much issue, but we do know that there's some issues with long-term complications of the arterial switch. So I guess we have to be very selective with the patient. My approach would be to follow up these patients who are well. These are the ccTGA patients with no anatomy. And when they start having the tricuspid regurgitation or when the septum is starting to shift, if they are within that young age group, then maybe consider at that time. However, sometimes this problem of the TR only starts when they are teenagers, and then you maybe wonder whether you have missed the boat in terms of training, and then you're looking at tricuspid valve replacement. So that's my take.
Yeah, Dr. Sifa, if ccTGA with VSD, for instance, you close the VSD in young age, toddler or in less than 5 years of age, would you do also a pulmonary artery bending as a prophylaxis?
Yes.
To prefer, yes,
You
to
mean in a physiological correction?
repair, yes.
Physiological repair, yeah, okay. Because to be honest, I have not done a physiological repair, because by the time I came into practice to do, to deal with ccTGAs, I've always gone on the anatomical repair pathway. But what I can tell you is that, I think if you have already closed the VSD on a physiological repair, I'm not sure whether it really, you may be able to put a band, but how much it will help in the future with the, with your septal shift and your regurgitation, or protect your systemic right ventricle from failing, I may not be able to give you any information on that, because I really don't have much experience, and I'm not sure whether there's much data that has come out from that, unless someone else can, probably share their experience.
So
Because-
Siva, sorry, just to ask you back the question you asked all of us cardiologists. What is your take about doing this routine LV retraining in this ccTGA patients during the infancy or early in the childhood? What are your thoughts? And then subjecting them for a double switch. What are your thoughts?
For me, I think there are a couple of subset in this of patients in this. Number one, if you have a ccTGA with a VSD, then I think it makes it very simple. Then, I certainly would want to, subject them for early surgery. In that case, I would recommend to a band in, infancy, and then they can go in for, anatomical repair by the age of 2 years or so. But if they don't have, if they have an intact ventricular septum, then in that too, you have two subgroup of patients. Some of them have a subpulmonic kind of obstruction. And this group of patients, they are, naturally kind of having a band wherein they do not have any kind of problems where, they will have a gradient across the, the outflow tract. So that kind of protects their morphological LV. So I think probably I would just sit on them, don't do anything, and wait and see what happens in the future, because some of them there are some of the patients who just go by in the natural history without having to do anything. But the only problem comes in is if you have a patient with the intact ventricular septum, and that's where the dilemma is right now. And now looking at, we are having a lot of patients with problems, especially I would look at how the systemic right ventricular tricuspid valve morphology is. If the patient at the outset itself is having the so-called epsinoid kind of a valve, I think this is going to be a substrate for problems to occur in the near future. So if that is the case, I would certainly recommend to do an early band and subject the patient for a anatomical repair in the near future, because that is the group of patients that we always seem to be landing up in trouble, especially when they have some kind of a morphological issues in the valve. But if the valve is morphologically pretty okay, then I suppose I will still wait and don't do anything and let the patient grow. And if there are any signs of some tricuspid regurgitation coming in, then probably I would just band and then wait and see how it goes. I definitely will not, push for a double switch for the reasons that you have mentioned. We really don't know how the long-term outcomes are going to be. So this is my take, Dr. Geeta.
I would like to weigh in on this. Hi, this
Yeah,
is
actually, we will get this answer from Professor Barron's talk, actually, yeah. The long-term result of anatomical repair. And as Dr. Gita has mentioned, that this also will have problems in the future.
So my question that I would like to put forward is that, you know, I think I'm not sure whether you all would agree with me, but I think, you know, we need to give consideration to the anatomy of the tricuspid valve, the morphology, you know, in the sense, what kind of tricuspid valve the patient has got from the outset. Because I think that will definitely have a huge impact on what we need to decide in the future. I'm not sure whether there's any kind of studies on that has been published, but I certainly feel that we need to give due consideration to that too. Because if you have from the outset a valve that doesn't look good, then we certainly know that this particular valve is not going to hold for a long period of time. So if that is the case, should we still leave them alone without intervening, or just wait until, you know, they go into serious trouble in the future and then try to deal with it? I think this is something maybe, you know, in fact, Prof. Tanjuli can make some recommendation, because you see so many patients that come to you with the tricuspid issue. So is there any kind of a substrate of patients you think probably is better, don't wait too long, try to get them done before?
Yeah, so I think in the patient with ccTGA, it's important to understand what is the cause for the severe TR. So if the cause for the severe TR is due to the epistenoid abnormality of the tricuspid valve, then we know once you have severe TR, you're going to get RV dysfunction. There's a couple of papers that's going to start at about 5 years. So you wouldn't want to wait too long, right? Because this is going to be severe TR causing worsening RV dysfunction in a systemic RV. So this is different from a patient who, because the tricuspid valve is completely normal, and that because the RV is becoming more globular, coaptation problem, and then you get severe TR. And then, you know, so there's a completely two groups of patients. So I think with epistenoid, you probably have to work, you have to probably consider tricuspid valve replacement earlier, certainly before the RV dysfunction comes in. For the other group, it may be concomitant. You get the systemic, you get the severe TR as the RV worsen because of the change in the globular shape of the RV. Yeah. So the patients, the two patients that you presented, the second patient with the epistenoid severe TR, even though the RV function is okay, I think that one you probably won't want to sit too long until you start to see RV dysfunction. It might be a bit late. Yes. And the second patient, as the RV gets, the first patient, the lady, where the RV is going to get worse, the TR will get severe. That one's a little bit tricky. What do you do because there's RV dysfunction? I hope, is this kind of clear?
Yeah.
Yeah.
I would like to weigh in on this. Hi, Siva. You know, the question of routinely preemptively banning everyone with ccTGA without VSD and LVOD obstruction is something that we always debate about. I think the issue with banning is not just about, you know, committing ourselves to double switch and worrying about the complication of the double switch. It also has to do with whether the LV copes with the banding. So you can see that some patients after the banding, if we subject them from double switch, they do well, but as a small group of patients, the LV eventually fails. If you look at David Barron's previous paper on the long-term outcome of ccTGA, you see that the patients post-Rastali, ascending Rastali actually does much better than those with double switch. And one of the things that we thought about was whether some of the LV doesn't really cope with the high systemic pressure after the double switch. Whether, you know, subjecting all patients for double switch eventually is a wise thing to do. I don't think there's an answer right now.
Yeah, I agree with Leong. before you subject the patient to PA band, assessment of the subpulmonic LV function is equally important, and that may tell you why some patients do poorly and some patients do better. There may already be some intrinsic LV dysfunction in certain groups, and then you put a band, and then the LV starts to fail because it just cannot cope with the increased afterload.
Yeah. Dear colleagues, I think I have to finish the session because time is up. Well, as a conclusion, I would say that the natural history of ccTGA is very variable. These patients should be followed up very closely and considered for intervention at the first sign of right ventricle dysfunction. Pulmonary artery bend split the IVS and forces it to the right side, the right side, and which provides supportive to the tricuspid valve, controlling tricuspid regurgitation, and may maintain right ventricle function. One of Professor Barron's paper strongly bets for pulmonary artery bending at the first, in the young age, yeah? Because well, it's like a prophylaxis pulmonary artery bending, and because this minimizes the risk of left ventricle failure later in the life. This is because the left ventricle plasticity and remodeling is maximized if pulmonary artery bending start early, perform early. And there is a paper actually that proven that if it's performed below 2 years of age, then the result will be very good compared to the older children above 8 years of age. Tricuspid valve replacement does have a role if right ventricle function is well preserved, or for those who start to develop failure, effective in patients with resynchronized therapy can be very effective in patients with conduction abnormality. Some other type of surgical has been discussed by Dr. Siva Kumar, and hopefully this enlightening session will improve our practice. Thank you very much to Dr. Professor Tan Julie, Professor David Barron for sharing your expertise, and also Dr. Ahmad for presenting the interesting case. And I would like also to thank Dr. Siva, Dr. Gita, and Dr. Leong for contributing the discussion. You all make this learning session exciting and fruitful for all of us. I would like also to thank all the participants of this webinar. It is unfortunately that the COVID-19 pandemic has impacted the chance of us to meet in person, to exchange ideas, learn from each other. Nevertheless, with the leverage modern technology, our colleagues from IGN were able to bring world distinguished speakers to share their expertise. This online conference is initiated with the objective to improve the understanding and care of patients with adult congenital heart disease within ASEAN countries. The organizing committee provided another 2 series of learning sessions on next Tuesday evening, and I wish you don't miss it because it will be very interesting cases. Thank you very much. Good evening and goodbye. Stay safe.
Thank you.
Bye-bye.
Thank you, everyone.
Thank you. Goodbye. Take care.
Thank you. Take care.